students, and welcome to chapter 22, dealing with our respiratory system. We're going to have 3 separate videos, and this is part 1 of the 3 dealing with our respiratory system. Now when we look at breath, it represents life. Now, of course, breath is the very first breath that we take as a newborn, and as well as the last gasp that we take in the process of dying, or last breath of a dying person. Now, all body processes it directly or indirectly requires ATP. ATP is basically our energy. Now, when we require energy, we need oxygen, and in the process of requiring oxygen, it produces this carbon dioxide, which is released out when we exhale. Now, this drives the need to breathe, to take in our oxygen, as well as to eliminate carbon dioxide. Now, the respiratory system is an organ system that rhythmically takes in air and expels it from the body. And in that process, it's going to supply the body with oxygen and expelling carbon dioxide. Now, when we look at the respiratory system, it consists of tubes that are going to drive air to our lungs. So here are the various, this is the respiratory and the cardiovascular system. So the oxygen, it diffuses into the blood, and carbon dioxide diffuses out. Now, the respiratory and the cardiovascular system, they work in conjunction with each other, and that's to make sure that our tissues are receiving enough oxygen, as well as releasing the carbon dioxide from the various tissues. We don't want to build up carbon dioxide. Now, them working together is considered to be, or is termed, the cardiopulmonary system. Now, disorders of the lungs directly affect the heart, and vice versa. So obviously, if someone is suffering from some type of cardiovascular disease, most likely the individual will definitely have respiratory disorders. So someone suffering from COPD, they will definitely have some type of heart issues. As you can see right here in the diagram, how we have blood coming from the heart, your deoxygenated blood entering into the lungs, picking up the oxygen and entering back into the heart. You see here that if there's any problems with our lungs, definitely the heart is going to be impacted, and vice versa. Now, the respiratory system and the urinary system collaborate to regulate the body's acid-base balance. As I go through this video, or these videos, sorry, please pay attention to the bolded or the colored words. You are going to see those again, so please pay attention to them. Alright, so the respiratory system has approximately three meanings. Your book talks about 2, but it has 3. It deals with the meaning for respiration, ventilation of the lungs, which is basically breathing, the exchange of gases between the air and blood, and between blood and the tissue fluid, and lastly, the use of oxygen in cellular metabolism. These are the 3 meanings of respiration. Now, when we look at the functions of the respiratory system, we have about 8 functions. Let's go through the very first 4. It provides oxygen and carbon dioxide exchange between blood and the air. It serves for speech and other vocalizations. It provides the sense of smell. It affects pH of blood fluids by eliminating the CO2. So, of course, if we have an increase of carbon dioxide within our tissues, within our blood, it increases our hydrogen levels, which in turn will decrease the pH value of our body fluids, which is something we do not want. 5th, we have the function Fifth function, it affects blood pressure by synthesis of vasodilator, which is that the angiotensin II. Number 6, breathing creates pressure gradients between the thorax and the abdomen that promotes the flow of lymph and venous blood. It prevents blood clots, which will appear in the cerebral, the coronary, or renal circulation. So about cerebral, we're talking about the head, the brain. The coronary, we're talking about in the heart. In renal, we're talking about in the urinary system. So it prevents these particular clots by filtering small blood clots by filtering small blood clots from the bloodstream and dissolving them. And lastly, breath holding helps expel abdominal contents during urination, defecation, and as well as childbirth. So that's you holding it or you pushing things out, especially during defecation and of course during childbirth. And that holding of the breath during any type of exertion is considered to be the Valsalva maneuver. Alright, so we have these principal organs. Now the principal organs of the respiratory system are the nose, the pharynx, the larynx, the trachea, the bronchi, and the lungs. These are the primary organs of the respiratory system. Now, of course, when that air comes in, which we'll get into details about it, it stops at the alveoli, which is these small little mini sacs that you'll find within the lungs. Okay, and this is where you have gas exchange occurring. So the air will flow in, the gas exchange will occur here, and then the air will flow right back out through the same those same main or principal organs. So there are two divisions of the respiratory system. We have the conducting system and the respiratory system. When we look at the conducting system, it consists of passages that serve only for airflow, essentially from the nostrils through the main bronchioles. And in this division, there's no gas exchange. So that's coming from the nose all the way down to the bronchioles. The respiratory system now, that consists of the alveoli, which you see here, and other distal gas exchange regions. The airway from the nose through the larynx is also called the upper respiratory tract, which I'll get there in just a second. So we have two divisions, the conducting system, the conducting division, and our respiratory division. One is from the nose all the way to the bronchioles, and there is no gas exchange occurring. It's just a straight flow down to our bronchioles. The respiratory system is that second division where gas exchange is going to occur, and it involves the alveoli as well as any type of distal gas exchange regions. So we have two tracts. I kind of jumped ahead of myself a few seconds ago. So we have two tracts. We have the upper respiratory tract and we have the lower respiratory tract. In the upper respiratory tract, that consists of the nose as well as everything else down to the pharynx. So that's going to deal with air coming in from the nose, as you see here, into the nasal cavity, down to our larynx. This is all the upper respiratory system. We have the nasal cavity, the pharynx, the larynx, upper respiratory system. Then we have our lower respiratory system. That's from there's organs from the trachea all the way down to the lungs. So that's the trachea. We have the primary and our secondary and tertiary bronchi, which is, you don't see the secondary and tertiary here, and as well as our lungs, and of course the alveoli. Okay, those are all the lower respiratory tract. I'll repeat that again. It's the trachea, the primary, secondary, tertiary bronchi, the bronchioles, the alveoli, and our lungs. Those are all involved in that lower respiratory tract. You may have heard of someone, oh, they have an upper respiratory tract infection. So when it's sick, that means there is inflammation or some type of illness occurring within this particular area involving these organs, the larynx, the pharynx, and of course within that nasal cavity. When I have a sinus infection, if you have a sinus infection, they considered it as a upper respiratory tract infection. But then when you have phlegm and mucus accumulating within your bronchioles and difficulty breathing, they'll consider that as a lower respiratory tract infection. Okay, you might hear wheezing or rattling of the lungs when you use a stethoscope to listen or oscillate the lungs. All right, so here let's get a different view of our respiratory tract. Yes, our respiratory system. Here we have our nostrils. You see in here we have our nasal cavity. Okay, we have air passing through when we inhale, passing through our nasal cavity. Of course, we have our hard palate, which is the roof of the mouth, that hard bone. Okay. Then we have our posterior nasal aperture. So air is going to pass through all of this here. We have our soft palate, which is the back of the mouth, very close to the back of the throat, which people commonly say. We have our pharynx, which is the extreme back of the mouth, past the soft palate. Then we have our epiglottis, which moves up and down depending if we are eating or if we're breathing. Okay, if we're eating, it moves up. If we're breathing, it flaps down to cover. No, if we're breathing, it stays up. If we are eating, it closes down to close off this entrance here into the trachea, so no food enters into our lungs. Moving down further, this is the esophagus, and this here is our trachea, and then our larynx, then our trachea, and of course we have our lungs on either side, our left and our right lungs. This is our left, and this is our right lungs. And of course we have our diaphragm that obviously does play a role with respiration. Okay, so let's move on. So what's the function of the nose? Function of the nose basically is there to warm, cleanse, and humidify any air that we inhale. If it's cold outside, if we breathe in too quickly, if we don't have something that covers over our nose that doesn't cover over our nose, you might eventually experience cold or pain in your chest, breathing in that cold air, and that's because the air hasn't had enough time to cool or to warm down, to warm before it enters into that respiratory tract. Another function of the nose, of course, is going to detect odors in the airstream. It could be pleasant, it could be very potent, or something not pleasant at all. Then it serves as a resounding chamber that amplifies the voice. So picture someone plugging your nose when you're talking. It does change your voice, the tone of your voice slightly. Now, nose extends from the nostrils, also called nares, to a pair of posterior openings called the posterior nasal apertures. Okay. So when we look at the facial part of the nose, of course we have our nasal bone, and we have cartilage, our hyaline cartilage, right after, or yes, to the distal aspect of our nasal bone. Now it does have a superior half nasal bones, as well as the maxillae. So its superior half is supported by a pair of small nasal bones medially and by the maxillae laterally. Now the inferior half is supported by lateral Here we go. Lateral meaning on the sides. Lateral and alar cartilage. So here's our lateral cartilage, lateral nasal cartilage, and here is our greater alar cartilage. Now the flare portion of our nose, or the flare portion at the lower end, they're called the ali nasi, and it's shaped like the alar cartilages and dense connective tissue. So here we get a better view of the flare portions of our nose, which is called the ala nasal. Okay. Here's the roof. Here's the bridge. Here is our dorsum nasi, and here's the apex of our nose, and of course our nares, also called our nostrils. Okay. Then we have this little piece in the middle called the nasal septum, and this small little indentation here is called the philtrum. Philtrum. Okay. So here is another diagram of the nose involving the bones and the cartilage and a little more details. Here we have our nasal bones. Hopefully you guys remember that from might be 201. Here are our nasal bones, and we have our lateral cartilages, and we have our septal nasal cartilage. And of course, on either side, we're going to have our minor and our major. Here's our minor and our major alar cartilages. And of course, the flares are made of dense connective tissue. Okay, so let's look at the inner chamber of the nasal cavity. Now it's divided into, of course, we have a left and right half, and they're called nasal foci. Okay. Now the nasal septum, which I showed you before, that is what's going to divide. That's that wall that's going to divide the septums, the left and right septums, vertically. And it's a bone made up with involving hyaline cartilage. Now it has a vomer. Remember the vomer from the skeletal system. The vomer forms that inferior. It forms the inferior part of this septum. And the ethmoid bone, it forms its superior part. So here is the entire nasal fossa. We have one on the left side and one on the right side. On the superior meaning upper, on the superior end, the superior end is formed by the ethmoid bone, and of course the inferior aspect is helped and formed by the vomer. Okay. Now the septum cartilage, it forms its anterior part. Anterior meaning the front. Okay. So we have the anterior aspect here. This will be our septal cartilage. Now the ethmoid and the sphenoid bones, they form the roof of the nasal cavity, and the hard palate forms its floor. So here's the floor, and here is the roof of the nasal cavity. Now the palate is going to separate the nasal cavity from the oral cavity, allowing one to breathe while chewing. The paranasal sinuses and the nasal lacrimal ducts of the orbits, they're going to drain into the nasal cavity. Now the nasal cavity, it begins with a small chamber called the vestibule just inside the nostril and bordered by the ala nasi. Now the vestibule is lined with stratified squamous epithelium, and has stiff guard hairs called vibrissa. And they're the ones that are going to block any type of debris that will enter into the nose. So if you, certain things like dust and hair, you have these little hairs, these hairs that are going to prevent a lot or the majority of the debris from entering into your nasal cavity. Yes, some will get through, and that's when you'll start coughing or sneezing. Okay. Now, posterior to the vestibule, the nasal cavity extends into a much larger chamber that does not have much open space. It is occupied by 3 folds of tissue. We have the superior, we have a middle, and we have an inferior nasal concave or tubernates, and they're going to project from the lateral walls. So from the lateral walls, which are on the sides. So we have superior, a middle, and we have an inferior concave or tubernates. And these are folds that you find within that larger chamber, within that nasal cavity. Now, beneath each concave is a narrow air passage called the midas. So you have these small little air passages right underneath here. Those are what you'll call the midas. See those little sections underneath here. Now, the narrowness of these passages and the turbulence, they ensure that the moist air contacts the mucous membranes on its way through to cleanse and humidify the air. Now we have various odors. Now the odors are detected by the sensory cells and the olfactory epithelium on the roof of the nasal fossa and adjacent parts of the septum and the superior concave. Now the rest of the nasal cavity, except for the vestibule, is lined with respiratory epithelium. Now both are ciliated cytostratified columnar epithelium with globulate cells, and these cilli are motile. Now globulate cells, they secrete mucus, and cilli, they propel the mucus posteriorly toward the pharynx. Now the nasal mucosa also contains mucus glands, and they're located in the lamina propria that supplements the mucus produced by the globulate cells. Now when we inhale foreign matter, it starts to stick to the membrane, to the mucus, and then it is swallowed into the digestive tract. Now the lamina propria is well populated with these type of lymphocytes and plasma cells, and it contains these large blood vessels to help warm any type of cold air coming in through the nasal cavity or through the nostrils. Now the inferior concave has an extensive venous plexus called the erectile tissues, or the swell bodies. Now every 30 to 60 minutes, the erectile tissue on one side swells with blood and restricts airflow through the fossa, and air is directed through the other nostril. The engorged side then has time to recover from drying effects. So here you have a diagram. Here we see the nasal concave. We have our superior, our middle, and we have our inferior. And these are the various folds that we were talking about. The the meatus. We have the inferior, the middle, and the superior meatus. Those small little passages, narrow passages where air will pass through. Okay. Let's move on to the next page. Alright, so we look at the pharynx. So we just talked about the nasal cavity, and we're looking at the pharynx. We're slowly moving down to the lungs. Okay, so when we look at the pharynx, which is also called the throat, it is a muscular funnel extending about 13 centimeters or 5 inches from the concave to the larynx. And it has 3 divisions. We have the nasal pharynx, we have the oral pharynx, and we have the laryngeal pharynx. When we look at the nasal pharynx, it lies posterior, meaning above, to the concave and above the soft palate. Now it's going to receive any type of auditory tubes from the middle ears, and it houses the pharyngeal the pharyngeal tonsils. So this is this area. Let's see if I can get it here. This is this area right here. This is our nasal pharynx area. Inhaled air turns 90 degrees downwards. So when we inhale, it turns 90 degrees downward as it passes through this nasal pharynx area. Now, particles larger than 10 micrometers generally cannot make the turn and become stuck to mucosa near the tonsils. So that's where you have a lot of accumulation of mucus or coal in your nose, and you'll have to blow it out because it cannot go a little any further down. Some cold gets down into the back of your throat. They'll say back of your throat, and sometimes you have to spit it out. Sometimes it goes a little further down when you actually swallow it. Alright, so that second region of the pharynx we have is the oropharynx. The oral pharynx, which is the space between the posterior region of the soft palate and the epiglottis. So here's our epiglottis, and there's our soft palate. This is the hard palate here. This is our soft palate. So now we're in this yellow section, our oropharynx region, and it contains the palatine tonsils. Our last region, our third region, is our laryngeal pharynx, and it lies mostly posterior to the larynx, extending from the superior margin, which you see here, of the epiglottis to the inferior margin of the cricoid cartilage, where the esophagus begins. Now, the oropharynx and the larynxpharynx, unlike the nasopharynx, they pass air, food, and fluids, and are lined with stratified squamous epithelium. So here you have it right here, that I just mentioned. So these are the only 2 regions where you have food, air, and drink passing through these areas. The nasal pharynx only passes air and is lined with cytopalmar epithelium, as it does make sense. Here is your oral cavity. This is your nasal cavity, and here's your oral cavity. It does make sense that we have just the oral pharynx and the laryngeal pharynx that would just deal with food, air, and drink, and the nasal pharynx only deals with air, only has air passing through. Okay. Alright, so now we're looking at the voice box, also called our larynx. It is comprised of it is a cartilaginous chamber, and it's about 4 centimeters in length. Its primary function is to keep food and drink out of the airway, but it evolved the additional role of sound production in many animals. So its additional role is phonation, which is the production of sound. So it has three main functions. Well, two main functions: to keep air and drink out of the airway, that's the primary function, and the additional function is phonation, which is the production of sound. It occurs in many animals. Now, the superior opening of the larynx is guarded by a flap called our epiglottis. At rest, the epiglottis stands almost vertical. During swallowing, these muscles, called extrinsic muscles of the larynx, they're going to pull the larynx upward toward the epiglottis, and the tongue pushes the epiglottis backward to meet it. And the epiglottis closes the airway, directing food and fluid into the esophagus. So basically, you're going to have the epiglottis flapping downward by the extrinsic muscles of the larynx to close this opening to the trachea, to allow food, or bolus, which is what it's called at this point in time, bolus, to enter into the esophagus. Now, the vestibular folds of the larynx, they play a greater role in keeping food and drink out of the airway. That's why at times growing up, our parents always said, stop eating and drinking, stop eating and drinking. That's to make sure that the bolus of the food will go down into the right tube, and you're not going to choke on your food. So here's a better look at our larynx, which is 4 centimeters, as I mentioned earlier, 4 centimeters in length, about 5 inches. Here we have our epiglottis. Here's our anterior view. Here's our posterior view. And here's our medial view. So this is like a side view, and did a cross section of what it looks like. Okay. So here's the epiglottis. This is what's gonna close down when we're eating, but stay up when we are talking. Okay. And that's vertical position. So if you have your books, see if you guys can follow along, because I'm going to go into a little more details of the structure of the larynx. Now with infants, in infants, the larynx is high in the throat, and the airway is more or less continuous from the nasal cavity to the larynx, allowing the infant to breathe continually while swallowing. So when we look at the framework of the larynx, it consists of 9 cartilages. Let me see if I have it on this one. Yeah. It has 9 cartilages. Now the first 3 are solitary and relatively large. Okay. And the remaining cartilages are smaller and occur in 3 pairs. So let's look at the very first one. We have our epiglottal cartilage. Right? Here's our epiglottal cartilage. It's the most superior and the spoon-shaped supportive plate in the epiglottis, hence the name. The largest, which is the thyroid cartilage, is named for its shield-like shape, and it covers the anterior, which is the front, and the lateral aspects, which are the sides, and forms the Adam's apple peak in males. So the thyroid cartilage is what forms the Adam's apple peak in males. You're going to see that question again, so make sure you guys pay attention, please. Now the ring-like cricoid cartilage. Let's get this moving. Here we go. Here the ring-like cricoid cartilage. You see here in the anterior view as well as the posterior view is located inferiorly, which is below, and it connects the larynx to the trachea. So here's our trachea section, and here is our larynx. So this cricoid cartilage is going to connect the trachea with the larynx. Now the thyroid and the cricoid cartilages, they constitute the box or the voice box. So the thyroid cartilage as well as the cricoid cartilage, they constitute the voice box. Now the remaining cartilages, of course, I said that they're smaller, and we have 3 pairs. We have the posterior to the thyroid cartilage are the 2 arytenoid. Here we have in the posterior view. Here we go. The arytenoid, and attached to the this particular cartilage, attached to the arytenoid cartilage, on the upper ends is a pair of these little horns. See these small little horns there? That's called the corniculate cartilage. Now these two, the arytenoid and the carotenoid, let me pronounce it better, corniculate, sorry. Those help with the function of speech. Okay. Then we have a pair of cuneiform cartilage, as you see here in the medial view here, the cuneiform cartilage, and that's what's going to support the soft tissues between the arytenoid cartilage and the epiglottis. Okay, so make sure you go through these 9 cartilages. We have the 3 large ones, which I said were the epiglottic, the thyroid, and the cricoid cartilage. And then we have the remaining smaller ones, which occur in 3 pairs. So that gives us our 9. So this is 1, our thyroid, which is one of the larger ones, the thyroid cartilage, our epiglottal cartilage, as well as our cricoid cartilage. So those are the 3 main ones. So it shows this 1 of each. Then we have our remaining cartilages, which are the arytenoid, the cuneiform, and the coronate. So since there's pairs of these, 2, 4, 6. So there's 2 arytenoids, 2 cuneiforms, and 2 corniculates. So that's 2, 4, 6, and then we have 1 cricoid, 1 thyroid cartilage, and our epi and 1 epiglottic cartilage. That gives us our 9 cartilages that make up, or that consist of the framework within the larynx. So here I have the various descriptions of each. I wanted to show you guys the diagram while I go through the various 9. Okay, so everything I was just speaking about is right here. Okay, so if you have printed off the PowerPoint, you'll actually get you can actually follow along with me. Okay. Now, a group of fibrous ligaments, they bind the cartilage of the larynx together to the adjacent framework of the neck. Now, superiorly, there's a broad sheet called the thyrohyoid ligament, and that joins the thyroid cartilage to the hyoid cartilage. Let's see. Alright, so inferiorly, the cricoid tracheal ligament joins the cricoid cartilage to the trachea. Now, collectively, the above ligaments are called extrinsic ligaments because they link the larynx with other organs. Now the intrinsic ligaments are contained entirely within the larynx, and it links its 9 cartilages to each other. 2 pairs of intrinsic ligaments, the vestibular and the vocal ligaments, extend from the thyroid cartilage anteriorly to the arytenoid cartilage posteriorly, and then they support the vestibular folds and the vocal cords. Now the inferior wall of the larynx has 2 folds on each side that are going to stretch from the thyroid cartilage in front to the arytenoid cartilage in the back. We have the superior vestibular folds, and they play no role in speech but close the larynx during swallowing, and they are supported by vestibular ligaments. Now the inferior vocal cords, also called the vocal folds, they produce sound when air passes between them. The vocal cords and the opening between them are collectively called the glottis. So here we have the glottis, these particular folds that you find. Right there between the vocal cords and the opening. I'm sorry, they're set up. They're those folds. Let me get this correct. Here we go. Here are these folds between. The folds that you'll find between the vocal cords. Or it's the opening. I'm sorry. It's the opening that you'll find between the vocal cords. Okay. So from here to here would be your that opening that we're referring to between the vocal cords. And look a little bit further down with all those ridges, that's your trachea. Okay, and here's your epiglottis. This is a slight view of the epiglottis right in here. Okay. Alright, so let's see where we are. Alright, so when we look at the intrinsic muscles, they're the ones that are going to control the vocal cords. They're going to do that by pulling down on the corniculate and the arytenoid cartilages, causing this cartilage to pivot. Now, depending on their direction and the rotation, these arytenoid cartilages, they're going to abduct or adduct the vocal cords. So we're talking about abduction. If you remember from 201 with your muscle movements, abduct means to move away from the midline. Adduct means to move towards the midline. So with those particular movements, it will determine what type of sound that we're going to get. Now, air force between an adducted, this is your adducted vocal cords, and it vibrates them and produces a sound. Now, in adult males, the vocal cords are usually longer and thicker, and they vibrate more slowly, producing that low-pitched sound that is a lot lower than that you'll find in females. Now, loudness is determined by the force of the air that's being pushed out through the cords. Like if someone's yelling, there's a lot more force coming through, so that will give us that loudness that we're looking at. Now, the crude sound from the larynx are formed into words by actions of the pharynx, the oral cavity, the tongue, and the lips. Okay, so here's this information I was just talking about. I forgot to change the slide, I'm sorry. Okay, so here we have the adducted, here's another view, the adducted vocal cords. And here we're at our abducted, add, and our abducted vocal cords. And you see that when they're taut or they're close together, how you have that higher pitched sound, and if they're a lot wider or the abducted, gives off a different sound. You notice how the cartilages have shifted slightly. The position of the cartilages has shifted. The retinoid here looks vertical. No, sorry, horizontal. As well as the corniculate cartilage. But then when you abduct them, you notice what happens to the those two cartilages. The arytenoid moves upward and swings laterally, and the cuniculate also swings and turns medially, actually, just the way it is positioned. So slight positioning, the swinging of the two cartilages, which helps with moving these vocal cords. Okay. All right, now we're on to the trachea, or windpipe. Now, it is a ridged tube about 12 centimeters long and 2.5 centimeters in diameter, and it is anterior to our esophagus. Now, the trachea is supported by 16 to 20 C-shaped rings of hyaline cartilage. Now, the open part of the C faces posteriorly, where it is spanned by a smooth muscle, the trachealis. Now, the gap in the C allows room for the esophagus to expand as swallowed food passes by. The trachealis muscle is going to contract or relax to adjust to any type of food or drink that will pass through the trachea. The inner lining of the trachea is a cytostratified columnar epithelium composed of mainly of mucus-secreted goblet cells, ciliated cells, and short basal stem cells. Now, the mucus traps involves particles. The mucus traps inhaled particles, and the upward beating of the cili, it starts to move mucus toward the pharynx, where it is swallowed. So they both play a role helping each other. The mucus is going to trap any type of particles that are inhaled, and then of course the cili is going to move, and then the upward beating of the cili is what's going to help the mucus move towards the pharynx, where it's going to be swallowed. Now, the connective tissue beneath the tracheal epithelium contains lymphatic nodules, mucus and serous glands, and the tracheal cartilages. Now, the outer layer, called the adventitia, is fibrous connective tissue that's going to blend into that of other organs of the mediastinum. So here we have our adventitia, and here is our trachea. You see how it is the outer layer of the trachea? And of course it's going to blend into any type of other tissue or organs that are surrounding it. Okay. Oops, sorry. Okay, let's move on to the trachea. Tracheostomy. Now, when we look at tracheotomy, it's just a temporary opening in the trachea, and you'll find it inferior or below the larynx, and that's where they're going to insert a tube. You have to intube, inserting air, and that's to help with airflow. Now, if someone is suffering from suffocation or asphyxiation, you'll have the medical care provider would insert a tracheotomy to help the person to breathe so they would not suffocate. So this tracheotomy, it prevents asphyxiation due to upper airway obstruction. So we're looking anything up here in the pharynx, in the oral cavity, nasal cavity, also in the larynx, any type of obstruction up there. Inhaled air debris, the nasal cavity, and is hot humidified. Now, if left for long, it will dry out the mucous membranes of the respiratory tract. Now, it becomes encrusted, and then it starts to interfere with clearance of mucus from the tract. So that's why it's only temporary. And of course, if it's left in there too long, it will cause infection. So here we have a beautiful view of our trachea. You see these C-shaped rings that make up the trachea. Okay. And here's another view of it here. Now we talked about our cartilages. There's 9 cartilages. Here's our thyroid cartilage, our cricoid cartilage, and here is our trachea. Try to remember this picture because we're going to move on to our main bronchiole. Okay, our main bronchi, I'm sorry, with our secondary and tertiary bronchi. Now here's a view of the lungs. We'll be moving on to the lungs in just a few minutes. Here we have our trachea, and then we have our main bronchi, also called the primary bronchi. The first branch here will be considered to be our middle lobal bronchus, but also our secondary bronchi, as well as our tertiary bronchi. So every time it branches off, this is our main, this is our secondary, and then we have another one here. This one shows it. These are our tertiary. It's a little bit shorter up here, but we'll get into that as to why it is. Okay. Alright, so let's look at our lungs. Our lungs are somewhat cone-like shape. It has a broad concave base resting on the diaphragm. So this is the section that's going to rest on the diaphragm. So this is the base of the lungs, and a very blunt peak called the apex. So here's the apex, and this is the base of our lungs. And this apex projects slightly above the clavicle. You guys remember where the clavicle is? Okay. Now, the costal surface is pressed against the rib cage, and the smaller mediastinal surface, it faces medially. The mediastinal surface, it exhibits a slit called the hilum. You see, well, you really can't see if I have another diagram. No, but there's a slit in here, called the hilum, through which the lungs receive the main bronchus, blood vessels, and lymphocytes and nerves. Now these structures, they constitute the root of the lungs. Now the lungs are crowded by, of course, adjacent organs and do not fill the entire rib cage. They're not symmetrical. Now when we look at the inferior to the lungs and the diagram, much of the space within the ribs is occupied by the liver, the spleen, as well as the stomach. Now the right lung is shorter, and the left is shorter than the left because the liver rises higher on the right. The left lung is taller, narrower, and that's because the heart tilts towards the left. And on the medial surface, the left lung has an indentation called the cardiac impression. So here's our cardiac impression right here. This is our right. Remember, when you're looking at a diagram, make an X with your hands and point to the diagram. Your right hand will point to the left side of the screen, and your left hand will point to the right side of the screen. You have to remember that, because when I put a diagram on your test, you have to know which side is the left or the right. So this side is our right side. As you see, it is, well, not really in this diagram, but it is supposed to be shorter, and that's because we have the liver that is higher on the right hand side. The left lung is a lot taller and a lot narrower, and that's because we have the heart that sits and tilts to the left, and then we have this impression here called a cardiac impression, and this is where we have indentation. This is that indentation in the left lung because of where the heart sits. Okay, let's see if I can go back. Anything else I left? Oh yes, the lobes. When we look at the lobes, we have that the right lung only has 3 lobes. It has a superior, a middle, and an inferior. Now there is a groove that separates these lobes. It's a deep groove, and it's called the horizontal fissure. Horizontal fissure. I believe I have the name here. Here we go. A horizontal fissure. And of course, for some of them have the oblique fissure, which separates the middle and the inferior lobes. So the horizontal fissure, you see it runs directly straight across, which is our horizontal fissure that separates the superior lobe from the middle lobe. Then we have our oblique fissure, which makes sense by just looking at the diagram. Oblique fissure, it separates the middle lobe from the inferior lobe. And of course, on our left lung, we just have 2 lobes. We have a middle, and we have a superior and an inferior, and it's separated just by one or a single oblique fissure. Okay. Now when we look at the bronchial tree, it is a branching system of air tubes within each lung, and it extends from the main bronchus to about 65,000 terminal bronchioles. Okay. Now, arising from the fork of the trachea, so here's our trachea, and here is considered to be the fork. Like a fork in the road. When you're driving, you come to the fork in the road. Here is the fork in the trachea. We have a main or a primary bronchus, and it's about 2 to 3 centimeters long. Now, it's slightly wider and more vertical than the left. So the right side is more vertical, and slightly wider, more vertical, and of course it deals with the aspirated or inhaled objects. They usually lodge into the right bronchus more than the left, and that's just because of the size, because it's a lot wider and more vertical than the other. Now it gives off 3 branches, hence the 3 lobes. We have a superior branch, we have a middle branch, then we have an inferior branch, and they're considered to be the superior, middle, and inferior lobar, L-O-B-A-R. Okay? And they're the secondary branches, and you have 1 in each lobe. So our middle, our superior, our middle, and our inferior lobar bronchi are also called our secondary bronchi. So this main one, this is our main bronchi. See, bronchus. Our primary bronchus. When they branch, this primary bronchi has three branches. It branches off, and those are your secondary bronchi, and they're going to have three branches on the right side, and we're going to have two on the left, and that's for each of the lobes. So in your book, it's going to have what's it going to have? Superior lobal bronchi, or I'll call it secondary because I'm so used to call it secondary. We have our secondary bronchi, we have our middle lobar or secondary bronchi, and then we have our inferior secondary or lobar bronchi. So you're not confused, because I'm so used to saying first and second, for primary, secondary, and tertiary bronchi. Alright, so in the left one, the left main bronchi, which we have on this side, now it's about 5 centimeters long and slightly narrow. Now it gives off a superior and an inferior lobar or secondary bronchi to the two lobes. Now, in both lungs, the lobar bronchi branch into secondary or sedimentary or tertiary bronchi, and they're about 10 centimeters in the right lung and 8 centimeters in the left. No, sorry, they're about 10 in the right lung and about 8 in the left lung. Now, each one ventilates a functionally independent unit called a bronchopulmonary segment. So we have our main, I'm going to go over it again. After the trachea, when it comes to the fork in the trachea, we have our main bronchus, which branches off, forming our secondary bronchi, or which is our superior, our middle, and our inferior lobal bronchi. And on the left hand side, it also branches off into our superior and inferior lobal or secondary bronchi, which each branch off again into tertiary bronchi or segmental bronchi, where you have 10 on the left, 10 on the right hand side, and you have 8 tertiary on the left. So when we look at this bronchial tree, so when we look at this bronchial tree, we know that all bronchi are lined with ciliated cytostratified columnar epithelium. Now, the lamina propria has an absence of mucus glands and lymphocyte nodules. Now, all divisions of the bronchial tree contain elastic connective tissue that provides recoil for expelled air. The mucosa has a well-developed layer of smooth muscle, the muscularis mucosae, which contracts or relaxes to constrict or dilate any air that is passing through. Now, branches of the pulmonary artery closely follow the bronchial tree on their way to the alveoli. The bronchial tree is serviced by the bronchial artery, which arises from the aorta and carries systematic blood. We look at the bronchioles now. So here we see the primary bronchus, the secondary bronchus, and then it branches off again. So this is the main, that's the secondary, and This is our tertiary bronchi, and at the end of the bronchi, we have bronchioles, and they are continuous to the airflow that lack supportive cartilage and are 1 millimeter or less in diameter. Now, the portion of the lung ventilated by one bronchiole is called a pulmonary lobule. Now, bronchioles have a ciliated cuboidal epithelium and a well-developed layer of smooth muscle in their lungs, in their walls. Now, each of the bronchioles divide into 50 to 80 terminal bronchioles, the final branches of the conducting system. Now, these measure 0.5 millimeters or less and have no mucus glands or goblet cells. They have no cilia. Now, each terminal bronchiole gives off 2 or more smaller respiratory bronchioles that have alveoli budded from their walls. So when we look at this particular diagram, here we have the bronchioles. Here's our terminal bronchiole, which branch off into our respiratory bronchioles. And you see here at the end is our sac of alveoli, or alveolar. Each one is called an alveolus. One is called the alveolus. The group is called an alveolar sac or alveoli. Okay, what I forgot to mention is that the walls of the respiratory division of these of the bronchi, they don't have much smooth muscle, and they are not ciliated. Okay. Of course, they have alveoli budding at the end of the budding from the walls, like I mentioned. They're considered the beginning of the respiratory division since the alveoli participate in gas exchange, and they're divided into 2 to 10 alveoli ducts. And now, at the end, they'll have alveolar sacs, which look like grape-like clusters. Okay, which you'll see right here. They do look like grapes. Okay, so that's what you find at the end of the respiratory bronchioles. All right, here's another view, a microscopic view of the alveoli and the respiratory bronchiole. So here's our respiratory bronchiole. Here, here's our terminal bronchiole, a terminal bronchiole. And here we have our respiratory bronchiole, and then we have our alveoli ducts in our alveoli. And this is a nicer view of what everything looks like. Okay. Okay, so when we look at the alveoli itself, the alveoli, alveolus, oh my word, an alveolus is a pouch about 0.2 to 0.5 millimeters in diameter. Okay. Now, in contrast to frogs or any type of amphibians with their similar single-sac lungs, mammals have lungs with 150 million large sacs, which are those alveoli, which which provide about 70 meters square of surface for gas exchange. Now, the thin, broad cells called squamous or type 1 alveolar cells, they cover about 95% of the alveolar surface area. Now, the other 5% is covered by round to cuboidal type or cuboidal grate type 2 alveolar cells. Although they cover less area, the type 2 cells greatly outnumber the type 1 cells. Now, their functions are to repair the alveolar epithelium and to secrete pulmonary surfactant that prevents the alveoli and smaller bronchioles from collapsing during exhalation. Now, without this circumference, the walls of the deflating alveoli would cling together like sheets of wax paper. So this circumference is basically to make sure that things don't, the walls that the alveoli are able to expand and not stick together like paper, okay, or like glue. We want to make sure that the alveoli are going to expand, because if it doesn't, then we are not going to be able to breathe. The most numerous of all the cells in lungs are the alveoli macrophages, which are dust cells. These cells keep the alveoli free of debris by phagocytizing dust particles that escape entrapment by mucus. So those are the ones that escape and get past the mucus that we have within our lungs. Within our nasal cavity. We do have some that do escape, like I mentioned earlier, but we have these backup cells that are gonna keep track of those and try and get rid of the debris, the free debris they call it, by phagocytizing the dust particles. Now, in the lungs, they are infected or bleeding. They are also phagocytized bacteria and lose blood cells. Now, as many as 100 million of them, they perish each day as they ride up the mucociliary escalator. Now, each alveoli is surrounded by a basket of blood capillaries supplied by the pulmonary artery. So here is our pulmonary artery, arterial. If I don't know if it, yep, you guys should remember that. We have the arterial, we have the artery, goes to the arterioles, then the arterioles to the capillaries, then our venules to our veins, and then to the heart. Okay, you guys remember that because that was in chapter 20, dealing with the heart. Okay, the blood vessels. So that should be in chapter 20. All right, so here we have the pulmonary artery. Okay, and this is what supplies the alveoli with blood. As you see how it looks like a basket, like the book says, basket of blood capillaries. Okay, so the barrier between the alveoli air and the blood are called the respiratory membrane. Now and they consist only of squamous alveolar cells and the squamous endothelium cell of the capillary and their shared basement membrane. Now these have a total thickness of about 0.5 micrometers, in contrast to the 7.5 nanometer nanometer diameter of a erythrocyte. Now fluid must be kept from accumulating in the alveoli because it interferes with gas exchange. All we want is carbon dioxide and oxygen exchanging at this point, not fluid. If we have fluid, then we're going to have problems. Alright, so in the alveoli, wall has a thin film of mucus, and an excess liquid is absorbed by the blood capillaries. Now, the main blood pressure of the capillaries is only 10 millimeters per mercury, and ectopic pressure of 28 millimeters of mercury. So the osmotic uptake of water overrides any type of filtration. I'll go back to the picture. Okay, so the lungs have more extensive lymphatic drainage than any other organ in the body. So here's what I was talking about. I wanted to stay on that picture, you guys can get a good visual. But here's just talking about what I was what I mentioned concerning the basket of capillaries surrounding the alveoli, that nice respiratory membrane, which is that barrier between the alveolar air and the blood, and then what the respiratory membrane consists of. Okay. Here is talking about the blood or the fluid that we don't want to accumulate within the alveoli. And here we have, oh, here we go. Here's this diagram showing further gas exchange between the alveoli occurring within the alveoli. Okay. So here we have the basement membrane, which I talked about. The basement membrane consists of the squamous alveoli cell, the shared basement membrane, and the capillary endothelial cells. So this is the basement membrane. When we talk about respiratory membrane, those are the three components of it. And this is where gas exchange occurs. So you have carbon dioxide leaving from the blood, from the tissue blood into lungs, and then oxygen entering into the blood so that it can be transported to the various tissues that need it. Okay, I have a lot of diagrams there. Alright, so the surface of the lung, let's look at the lung itself and what actually is covering this lung, the lungs. The surface of the lung is covered by the visceral pleural, okay, which is a serous membrane that extends into the various fissures. When we talked about the various fissures, we have fissure that separates the superior and inferior lobes, the medial and the middle and the inferior lobes. Those are the fissures. So that's gonna cover the extents. Then we cover the outer part of the lungs as well as within the folds, so between the flaps of the lobes of the lungs of each lung. Okay. Now at the hilum, the visceral pleural turns back on itself and forms the parietal pleural. So here we have the visceral pleural, and it says it turns back on itself. Here we have it right here. It turns back on itself, forming the parietal. Forming the parietal membrane or parietal pleura. So that's when it says it turns back on itself, but it folds back, forming the parietal membrane. Oh, sorry, the parietal pleura, which adheres to the mediastinum, which is that inner aspect here, which you see. The inner surface of the rib cage, coming all the way around to the inner surface of our rib cage, and then of course the superior surface of our diaphragm. Now the space between the parietal pleura and the visceral pleura is called the pleural cavity. So that's that light blue area you're looking at right now. That light blue area is called the pleural cavity. That pleural cavity, get that right. That pleural cavity does not contain a lung, but rather wraps around it. The cavity contains nothing but a film of slippery pleural fluid. The cavity is thus termed a potential space, meaning there is normally no room between the membranes. Now, the pleura and the pleural fluid, they have three functions. And what are they? Reduction of friction, creation of pressure gradient, and compartmentalization. When we deal with friction of the fluid, we deal with the pleural fluid. It acts as a lubricant that eases blood expansion and contraction, and that's just to make sure that when we're inhaling and exhaling, it has a smooth ride with that movement. There's no grinding of or rubbing of the various tissues of the various organs with each other, like this aspect here, the inferior aspect of the pleura cavity, is to make sure that the lungs aren't rubbing with the diaphragm, or here on the lateral view where the lungs aren't rubbing with the rib cage and the muscles involved in keeping the rib cage together. Okay, like our pectoralis major and minor, all those various muscles that you'll find here. Okay. Then our second function is to creation of pressure gradient. The pressure gradient in the pleural cavity is lower than atmospheric pressure. Then our third one is compartmentalization, with the pleura, the mediastinum, the pericardium compartmentalize the thoracic cavities, and that's to prevent any type of spread of infection and diseases from one organ to the next. Okay. Okay, so let's talk about breathing, our pulmonary ventilation. Now, breathing or pulmonary ventilation consists of a repetitive cycle of inspiration and expiration. That's basically inhaling and exhaling. One complete inspiration and expiration is called a respiratory cycle. Now, quiet respiration is the way one breathes at rest. So right now you're sitting down listening to this lecture. This is considered to be your quiet respiration. Now, forced respiration, usually deep or rapid breathing, and you'll find that during any type of exercise or singing or blowing, coughing or sneezing, that's considered to be forced respiration. Okay. Now the lungs, they fill with air, and then they empty. The lungs fill with air and empty of air when their volume expands and diminishes due to the action of these respiratory muscles. Oops, sorry, forgot that went on right away. Okay, so I'm going to have a look at a small little video pertaining to the barometric pressure, just pressure within the lungs. Okay. Okay, so let's look at the respiratory muscles that are involved with inhaling and exhaling. These are skeletal muscles of the trunk, and we're looking at especially the diaphragm and our intercostal muscles. Alright, so the primary mover of the pulmonary ventilation is our diaphragm. Now when it relaxes, as you saw in the video, if you looked at the little diaphragm that they showed you, when it relaxes, it bulges upward and the lungs are at their minimum volume. This is when you've already exhaled and your diaphragm is actually in that concave shape. Shaped upwards, is moving upwards, okay? Let's see if I can draw it for you. Here's that in that relaxed. There's your diaphragm. Excuse my drawing, but here's your diaphragm in that relaxed state. Okay. Now, when the diaphragm contracts, it's tense and it starts to flatten. So that's when we begin to inhale. You see, when we begin to inhale, starts to flatten out a little bit more until it actually flattens, and this is full inhalation. So you take a deep breath in, it flattens out, and you blow it out, it starts to form, and it's back to its relaxed state. So this is called a relaxed, R-E-X, and this is the contraction. This is our diaphragm contracted. Let's put the ED in there. And here is it. Here's our diaphragm in that relaxed state. So when the diaphragm contracts, it tenses and it flattens somewhat, dropping about 1.5 centimeters in relaxed inspiration and as much as 12 centimeters in depth, during which enlarges the thoracic cavity. So remember, if you sit and you start to inhale and exhale, when you inhale, notice that everything starts to expand outwards, given that the enlarged thoracic cavity. Now the diaphragm alone accounts for about 2/3 of our pulmonary flow. Let's see if I can try to erase this stuff now. Okay. Alright. So several muscles aid the diaphragm as synergists. Synergists are muscles that help out the diaphragm. Okay, chiefly the internal and the external intercostal muscles. Now their primary function is to stiffen the thoracic cavity during respiration and prevent it from caving inward when the diaphragm descends. So when the diaphragm goes down, we don't want these muscles or the thoracic cavity to collapse. Of course, that'll cause damage to the diaphragm. Okay. Now they also contribute to enlargement and contraction of the thoracic cage, and about 2/3 of the air that ventilates the lungs. Now during quiet respiration, that's you sitting still, doing absolutely nothing, just breathing in and out, the scaling muscles of the neck fix ribs 1 and 2, while the external intercostal muscles, which basically on the side of the rib cage, they're gonna pull the other ribs upward like handles on a bucket. Okay, so we're going to pull them upward. Those are the side muscles of your ribs. Okay. Now these actions, they're going to increase. Let's see if it's here. Okay. Now these actions increase both transverse and anterior posterior diameters of the chest. Now transverse, where it goes across. Anterior posterior, you're looking at both front and the back. The front and the back portions of the chest. Now in deep breathing, the anterior posterior diameter can increase by as much as 20%. Now other muscles of the chest and the chest and the abdomen also aid in breathing, especially during forced respiration. That's us running now, or doing a type of exercise, I should say, and are termed accessory muscles of respiration. Now, the erector spinae, that's one that arches the back and aids in deep respiration. And if you're doing any type of exercise, either in the hospital or the doctor is taking your sorry, is about to check your breathing, to tell you to sit up straight, and take a deep breath in and out. And that's just to make sure that they're getting the proper sounds that they're looking for. But the erector spinae, which is the muscle that is around the spine, that helps you keep you erect, hence the name erector spinae, that's the one that aids in deep respiration. So they never want you hunched over trying to take a deep breath, because it's not going to work. They want you to sit up straight, and those erector muscles help keep you upright and help with allowing you to take these deep inspirations. Now, several muscles, they're going to elevate the upper ribs. That's the sternocleidoid muscle and the scalus muscle of the neck, the pectoralis minor, which a lot of the guys will know where the pecs are. Yeah, the pectoralis major and the minor. The major is the one that you actually see, and the minor is underneath. Yeah, the serratus anterior of the chest. Then we have the cartilaginous part of the internal intercostals. Now the scalus, that's the one that's going to elevate the upper ribs during forced respiration. So all of these muscles play a major role in helping us inspire during forced inspiration. Okay, so that's coughing, sneezing, doing any form of exercise. These are the ones that play a major role. These are the accessory muscles. All right. So normal expiration is an energy-saving passive process. Now the bronchial tree attachments of the ribs to the spine and the sternum, and the tendons of the diaphragm and other respiratory muscles spring back when the muscles relax. Now the muscles relax gradually in normal expiration, preventing the lungs from recoiling too suddenly. Now in forced respiration, the rectus abdominis, which is basically the abs, for those that don't remember, those are the ones that are going to pulls down on the sternum, which is the chest bone, the breastbone, and the lower ribs, while the interosus part of the internal intercostals, they pull the other ribs downward. Now these actions they reduce chest dimensions and expels air more rapidly and thoroughly. Now many other muscles that contribute to forced expiration, including the lumbar, the abdominal, and other pelvic muscles. I think I jumped ahead of myself. Yep, I did. Sorry. So many other muscles that contribute to forced expiration, including the lumbar, the abdominal, and even pelvic muscles. Now, abdominal control of airflow is particularly important in singing and public speaking. Now, the thoracic pressure also affects the abdominal pressure. Now, the depression of the diaphragm raises the abdominal pressure and helps expel the contents of certain abdominal organs, aiding in childbirth, urination, defecation, and vomiting. Okay, so let's look at the Valsalva maneuver. The Valsalva maneuver, it consists of taking a deep breath, holding it, and then contracting the abdominal muscles to raise abdominal pressure. So that's you taking in a deep breath, holding it, and then pushing something out, either through defecation, urination, vomiting, or in childbirth. So those individuals that have been through childbirth, they always tell you, okay, time to push, time to push. And what do? You take a deep breath in, and you push everything out. And sometimes, of course, some people, if they're constipated or have trouble with defecating, which is using the bathroom, defecation is stool, removal of stool from the colon. You will use the Valsalva maneuver. It's eventually not good because you can burst some blood vessels, so they try not to do that. Through defecation is not good. Urination definitely not good because you start to weaken the muscles. Yes, I'm drifting off into a different topic, but just wanted to throw that in there. Okay, so here are our various muscles that I spoke about that we'll see in inspiration and through forced expiration. So here you see where the insertion and the origin of these various muscles are. We have our sternocleidoid muscle. This is the one that's going up in towards the neck. You see where it's inserted into the manubrium. Okay, this is our sternum. Remember, in the skeletal system we have the manubrium, the body, and we have the xiphoid process. So our sternocleidoid muscle is going to elevate our sternum. Okay, it's going to pull it up. See all these arrows going up. Here's our clavicle. You see a little piece of the clavicle here. There's the other piece of the clavicle here, and we have our ribs. Our ribs 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then our other 2 floating, which you can't see. But we see our scalens, scalens, I think it's what's. Gotta get the pronunciation. They're going to elevate ribs 1 and 2. So you see the ribs right here. So the clavicle also is elevated slightly. They're not talking about any drastic movements, but there's slight movement in the clavicle, and of course the sternocleidoid would help with it moves just slightly, but the sternum as well as the clavicle. Then we have our scalens, which elevate or fix the ribs 1 and 2. Then you have our external intercostals, which you see here. Okay, external intercostals, what I said was at the side of the rib cage. They're going to elevate ribs 2 all the way to 12. Okay, we have our pectoralis minor, which you see here. They're gonna elevate ribs 3 to 5, 3, 4, and 5. This one's cut, so you really can't see that because that's 1, 2, 3, 4, 5. So that's 5, 4, and 3. Okay. Now internal intercostals, which you see here, which is closer to the sternum and attaching to our diaphragm, or close to our diaphragm, sorry, they will aid in elevating the ribs itself. So you see where the attachments are on each of the ribs, okay? And then our diaphragm here is what's going to descend and or drop or contract when we inhale, and then relax, go back up to this position, or position here during exhalation. Then during our forced expiration, we have other muscles that are going to come into play because we need a lot more. Of course, the diaphragm is going to come into play because we have to breathe in and out a lot harder. We have our rectus abdominis, these are our abs. Our rectus abdominis, that's going to depress the lower rib. So depress meaning to bring it down. You see the arrows going down. It pushes the diaphragm upward by compressing any of the abdominal muscles. Then we have our external obliques. Come on. The ones at the side, okay? Which are very difficult to actually define. They have the same definition or the same function as the rectus abdominis muscles. And then we have our internal intercostal pterosis part. And that's going to depress or bring down ribs 1 through 11 and narrow the thoracic cavity. Okay. Alright, so let's look at the pathway of air. That shouldn't have been there, but let's start. When we inhale O2 from the environment, it enters into our nares. Our nares are also called our nostrils. Then it goes into our nasal cavity, into our pharynx, down into our, past our epiglottis and our glottis, to our larynx, to our trachea, to our primary bronchus, also our main bronchus, to the lungs. But inside the lungs, we have the secondary and our tertiary bronchus, down to our bronchioles, that should have been an arrow, to our down to our alveoli, where we have gas exchange occurring. So now this O2, or oxygen-filled blood or air, meaning our O2, so it reaches the alveoli where we have gas exchange occurring. So the O2 would release into the bloodstream, passing the respiratory basement into the bloodstream, where it is facilitated and taken to the required muscles or the required tissue, picking up the carbon dioxide that's released from the blood cells back into the alveoli, and it goes to the same set of organs outward and back. It's the same pathway outward, where we will exhale it as our carbon dioxide. So this is the pathway of air. Yes, it is a lot of information. This part was just dealing with the various structures of the respiratory system. So hopefully you will remember it, and please look at the review sheet when I post it, or that is posted. Okay, we're going to move on to the second part of the respiratory system. If you have any questions, remember, just post it in the discussion board area under questions and answers.